Assalamualaikum and good evening, everyone. My name is Hafsa. I'm one of the members of MedTweetMY, and I am honored to be leading this CME MedTweetMY program. I'm currently practicing dermatology in Ireland, but I'm also passionate in teaching, and here we're actively involved in the tutorials and educational events organized. In fact, I have worked as a clinical lecturer in medicine before entering dermatology, and in this pandemic, we know that medical students and doctors, especially junior doctors, have limited exposures to learn clinical skills. We know this is an issue, and instead of focusing on the problem, we look at the solution and focus on what will give results. This is how we came up with this idea, CME MedTweetMY, an idea generated by MedTweetMY members who are really passionate in teaching. And we are planning to hold these sessions weekly, focusing on the core basic skills which are relevant to daily practice in medicine. So our first session will be ABGs Made Easy by Dr. Iskandar Mirza, internal medicine physician working in Hospital Tuanku Ampuan Najihah. But before that, I would like to invite our president, Dr. Khairul Hafiz Al Khair, to give a few words.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Hafsah, and thank you for all the MedTweetMy members and also all the committee that have been initiated this program, which is CME MedTweetMy, which is we have one theme that we think that want to pursue, that is back to basic. First of all, I want to thank all of you participate in this CME, which is this is the first CME that we have held after 5 years of our establishment as NGOs. For your information, and MedTweetMy is actually an NGO that giving health information, especially in Twitter platform. So basically, we are doctors in social media, and after a few years, we are actually embarked in the giving health information in the social media. So we think that we can expand our program, which is we give information and education to the all you medical students and young doctors as well. So I want to thank Hafsah, Dr. Norman, and also Dr. Iskandar that given these ideas in our WhatsApp group, which is our Bawangs group. So basically, they are giving these ideas that thinking that what we can do to help all our young medical students and young doctors, where we think that we know that the exposure that you get during this pandemic is minimum. So with this new approach, where we can actually help a meeting online, we want to take this opportunity to have to engage with all of you, and then to try to give as much as information and knowledge that we have to all of you. We think that we can actually contribute back, not only to our public, but to you all in the same fraternity. This is what actually we wanted. Why at the first place we wanted to actually help the CME MedTweetMy, and I feel really excited to see that within a minute, actually we have reached maximum capacity of Zoom meeting. Actually, we are thinking to upgrade it until 500 participants, but we are still a bit conserved. But looking at this people that coming in, and there some of you are waiting for 40 minutes before the program started. We felt really glad, and we try to actually improve our program. Maybe we start to have FB Live, and also maybe we can actually put it live in YouTube. But for now, we actually will have record this Zoom meeting, and we will upload it into YouTube after all this session is finished. Either way, my friend also said that I have just 5 minutes to talk. Then I hope that you all can enjoy and get benefit from the CME. Inshallah, we will do it weekly. and we tried our best to give as simple as possible the basic knowledge that you all need to have when you are actually in the hospital or in the fraternity in the future. Thank you so much, and I hope that you will enjoy. But maybe I can. We have a chat group. I think that maybe you can all introduce yourself, your name, maybe where you are working, or maybe where you are studying now, in what courses, so that in which university, so that we can have a glance actually where are you from, so that we know that we are actually have some interaction with you all. Thank you so much. I give it to Hafsa.
Okay, thank you, Chief. So on our for our first session, ABGs Made Easy by Dr. Iskandar Mirza. He is an internal medicine physician working in Hospital Tuanku Ampuan Najihah. Without further ado, I would like to invite Dr. Iskandar Mirza to present. Please, before we begin, make sure your mic is muted. If you have any questions, please submit it through the chat box. And I welcome Dr. Iskandar Mirza.
Okay, thank you very much, Dr. Hafsa. Okay, my name is Dr. Iskandar Mirza bin Amran. I'm currently working as an internal medicine physician at the Hospital Tuanku Ampuan Najihah, Kuala Lumpur, Negeri Sembilan. Okay, first of all, I would like to say good evening for those who in Malaysia viewers, and also good afternoon for those from Dublin. Okay, so actually I'm a bit overwhelmed because there's currently we have reached max participant 300, and now from the room we can see that there's still a lot of people actually waiting to be entered. But we're really sorry that we only can participate about 300 participant only. Okay, so let me we start with our session first. Okay. Okay. Okay, so today I'll be talking about arterial blood gases made easy. Remember, based on the topic also, you will know that is arterial blood gases made easy. So maybe on the next session, we're gonna do arterial blood gases the next level. Okay, so our aim today is to make sure that all the junior doctor really understand how to interpret ABG, so that you can know the interpretation and you can know actually what you have to need to do afterwards. Okay. Okay. Before we start, okay, I just want to know, to inform you guys that I'm the sorry. Okay, I'm the new members of the MedTweetMY. Thank you very much for the MTM community for admitting me for this joining me to the MedTweet family. And then okay, now we start first. So what is normal ABG? So how do you know the result is normal? This is the most important part. No, sometimes some of my junior doctors now actually they don't bother to really interpret the ABG. What they did is when they get the results, they just handed it to me or to the medical officer. So it will be very good if you actually know how to interpret the ABG and then make us impressed. When you try to interpret ABG, actually we can see your how do you try to think. And then, okay, first you need to know the baseline range for the ABG. So yeah, I'm going to talk it afterwards. From there, you will know whether the result is normal or abnormal. Okay, now first we look at what to look in ABG. Okay, of course, the first thing that appear in the ABG is the pH level. So which measures how many hydrogen ion in the sample. So you have to remember pH equivalent to the hydrogen level in the serum. Okay. And then next step is the carbon dioxide level. So this carbon dioxide level can detect the problem is from respiratory in origin or not. Okay. And then the last one will be the bicarbonate level. Okay. It will tell if the problem is related to the metabolic changes and referred to the renal system. Okay, so now this is the basic. So please remember this. We only look at the pH, carbon dioxide level, and the bicarbonate level. Okay, if you want to know more, like the base excess or anion gap, later we'll talk in the next level, the next session. Okay. Okay, so now let me show you the normal ABG levels. So it's very easy to remember this. Okay, first one is the pH. The pH level is will tell you about the hydrogen level. And then the normal level is from 7.35 to 7.545. And then the second one is partial pressure of carbon dioxide, which is from 35 to 45 millimeter mercury. And the last one will be the bicarbonate level, which is from 22 to 26 millimole per liter. Okay, remember this. Okay, so first is the ABG valid. Okay, so how to know is the ABG valid or not? First, you have to assess the internal consistency of the value using the Henderson-Hasselbalch equation. Okay, so and then this is the method how to calculate the hydrogen level. Okay, by calculating this, you can know whether you can have an idea whether the ABG is valid or not. Okay, not many does this, but if you do this, actually, it will improve yourself. Okay, so the hydrogen level is equivalent to 24 times PaCO2 level and divided by the bicarb. Okay, this is will show you roughly what is the hydrogen level in the sample, so that you can know what to expect with the pH level. Okay, these are the level of pH with the hydrogen level. It's quite difficult, but to make it easier for you, the lesser the pH number, the higher is the hydrogen level. Okay, so it's normal, right? Okay, so now if the higher the pH level, so be lower the bicarbonate level. So to make it easier for you to remember, just look at this level. Okay, if pH is 7.35, the approximate level of hydrogen is supposed to be 45. Okay, if the pH is 7.45, the approximate hydrogen level is supposed to be 35. So if you calculate the Henderson-Hasselbalch equation, if suddenly the hydrogen level is actually more than 45, okay, so you expect it become more acidic. The pH is supposed to be lesser than 7.35. Okay, if the level is less than 35, so means that the pH is supposed to be more than 7.45. Okay, if you can see, the pH level, the 0.35 and 0.45 almost disproportionate to the hydrogen level. So it make it easier for you to understand, to remember this. Okay. Okay. Now we talk about the hydrogen. How about now? How do you know? Now you already know the pH level. How do you know what is acidic or alkalotic? So the first one, if the pH is less than 7.35, we call it acidosis. And if the level of pH is more than 7.45, it will be alkalosis. So easy, right? Very easy. This one is a basic level that you need to know. And this is the normal level that I showed you previously. Okay. Okay. The third one is you want to know if the ORI pH or the acidotic or alkalosis. You want to know whether the disturbance is respiratory or metabolic. Okay. So respiratory causes, the PaCO2 level will be out of range. And the metabolic causes, the bicarb will be abnormal. So it's quite easy from here. However, don't worry. Okay, if you don't really understand, we'll go to the question. We have some few questions to make you really understand how to interpret the ABG. Okay, so how to know is whether it's respiratory or metabolic. Okay, if patient have respiratory acidosis, the first column there. Okay, so the acidosis will show pH will be lower, less than 7.35. Respiratory, to make it logical for you, the higher the PaCO2 level will be, the acidic will be the serum is. So if the pH low and the caused by respiratory, the PaCO2 will be very high. Okay, and then if the patient have acidosis with metabolic acidosis, okay, acidosis shows that pH will be low, but metabolic, and then the bicarb supposed to be also low. The PaCO2 supposed to be low also. Okay, and then the respiratory alkalosis will show pH will be alkali more than 7.45, but the PaCO2 is less than 35. Okay, and then metabolic alkalosis, we can see the pH is increased and PCO2 is increased. Okay. In primary disorder, the pH and the PaCO2 changes in opposite direction. So if we think it's from respiratory, you can see the pH will be high, okay, and the PCO2 will be low, or vice versa. The pH will be low and PCO2 will be high. Means that is purely respiratory problem. Okay. However, in metabolic disorder, the pH and the PCO2 change in the same direction. If the pH is low, the PCO2 will be low. The pH is high, the PCO2 will be high in metabolic disorder. So just remember this sentence, and then usually you will very easy for you to interpret the ABG. Okay, the fourth step is the appropriate compensation for the primary disturbance. Okay. Okay, if you have a metabolic acidosis, so the pH will be low, because the acidosis, the metabolic, so the bicarb also will be low. So if both the pH and bicarb is low, so the PCO2 will try to compensate by reducing the level of PCO2. So this is what you expect to see when you have metabolic acidosis. And also for the acute respiratory acidosis, there will be increase in bicarb level instead. However, in chronic respiratory acidosis, the bicarb level will be increased. But when you can see the equation here, actually it's 3.5 times from the acute respiratory acidosis. So example, the patient came, example is obstructive sleep apnea patient came with committed chronic pneumonia. So the patient will have type 2 respiratory failure, pH can be 7.2, and then the bicarb can be 30, can be very high, even, and the PCO2 of course going to be high because of the type 2 respiratory failure. It will be like 50 to 60, it's a lot. Depends on how the body mechanism to compensate the acidosis, okay? And then the next one is metabolic alkalosis will be increased in the partial pressure of the PaCO2. Okay, this will increase so that the pH can actually reduce from the alkalotic to normalize. And then the acute respiratory alkalosis also, there will be decrease in bicarb. And the last one is chronic respiratory alkalosis. Okay, there will be decrease in bicarb also. Okay, but 5 times the level of the acute respiratory alkalosis. So this one you have to know. If you really difficult for you to remember the equation, never mind. But at least you know what is going to happen to each of the expected compensation component. That is very important. Okay. So usually the compensation does not return the pH to normal. Okay, when this happens, even though you see there's a compensation where the PCO2 or the bicarb become low or high, but still the pH can't be met to the normal level. Okay, so this in this kind of case we call it decompensated metabolic or respiratory alkalosis or metabolic alkalosis or acidosis. Okay. Okay. The fifth step is we know the characteristic of acid-base disturbance. This one is to make it easier for you guys, okay, so that you really understand how to interpret the arterial blood gases. So in metabolic acidosis, the name acidosis shows the pH will be low, okay, it's normal. But the primary problem, if the pH and the bicarb reduce in the same time, so it will be the primary problem will be the metabolic. Okay, remember pH and PCO2 will inversely proportionate. If pH low and PCO2 is high, means that it's respiratory. Okay, but now when you see the pH is low and the bicarb is so low, means that it's already is a metabolic problem. Okay, so it's a metabolic acidosis. What we expect to the PCO2 level will be the PCO2 is supposed to be low to increase the pH level to the normal level. Okay, same as metabolic alkalosis. When we say alkalosis, pH will be high, metabolic, bicarb also will be high. It will same, the level will be increased, both will increase in metabolic causes. Okay, the PCO2 also will become high just to make the blood a bit acidic, to acidify the serum so that the pH can be reduced to the normal level. Same as the respiratory acidosis. When the respiratory acidosis, as I told you, the pH will be low, the PaCO2 will be very high. So then you know it's a respiratory causes. This one you have to remember, okay? And then the bicarb also will be high, just to make sure to reduce the to increase the pH of the level. And last one is a respiratory alkalosis. The pH will be high, PaCO2 will be low, and the bicarb will be low. So I think from here it already make you very easy for you to understand, right? How to interpret ABG. It's quite easy. You remember pH causes the pH and the bicarb level will be samely rise or reduce, elevated or not. Okay, but for the respiratory causes, it will inversely disproportionate. pH will be low, but the PCO2 will be high, or pH will be high, PCO2 will be low. That one is the respiratory causes. Okay. Okay. So easy, right? Okay. So now, how about we go for the summary? Okay. This is the summary. Okay, never mind for those who want to actually to revise more. Actually, we're gonna upload this in our MedTweet YouTube channel later on. Okay, we are also recording this session right now. So this is the how you interpret it. So when you see this test, then how to interpret the ABG. Okay, how about we go for some tests? Okay, I have 4 questions. So now we see how to interpret the ABG to make it easier for you. Okay. Okay, for number 1. Okay, so now I have a patient came in with a pH 7.36, PaCO2 of 50, and bicarb of 19. Okay, let's interpret one by one so that you really understand how to make a diagnosis from the ABG result. Okay, first we go to the pH level. Is the pH level is acidic, right? No, actually it's not acidic. It's a is a normalized. Okay. How about the PCO2? Is it elevated? Yes, it's elevated. How about the bicarb? Bicarb is reduced. Okay. In this kind of case, actually the normal level of pH is 7.35 to 7.45. So the patient level is almost the same. Almost actually is almost is compensated, and then but all part of the normal. So you expect is either the PCO2 is high or the PCO2 is high also, or the bicarb will be is very low. So in this kind of case, what should you think? What is the answer for this ABG? Will be the compensated respiratory acidosis. Why? Because the pH is normalized. Okay, pH already normalized here, but the PCO2 is high, so it's inversely proportionate from the pH level. So it's a respiratory causes in origin. The bicarb is lower because of the compensatory mechanism to the low pH. Okay. Now we go to number 2. Exercise number 2. Okay, now the pH also 7.36, almost acidic at the lower part, still normal. PaCO2 is 25, very low, and the bicarb is low. So from here, you know which one is correlating between each other. Is either from respiratory or metabolic. So pH almost acidic, 7.35. PaCO2 is reduced, and the bicarb is reduced. So if the pH is lower on the lower level and the bicarb also reducing, so instead is a metabolic causes. Why the PCO2 reduce is because to compensate, compensatory mechanism, so that the pH can be normalized. So that's why the pH is on the normal side of the level. So the answer would be compensated metabolic acidosis. So this one is quite easy, right? Okay. We go to the exercise number 3. Okay, now pH is 7.5, alkalotic. PaCO2 is 48, so it's a bit high, and then the bicarb is 32. Okay, also high. So if the pH is high, the bicarb is high. Okay, then you see, okay, we just separate first. Okay, pH is alkalotic, and then PaCO2 is elevated. Okay, and then bicarb is elevated. So when the pH is correlating with the bicarb level, which is increasing, so it's a metabolic causes. Okay, in this kind, the metabolic causes, the compensatory mechanism will cause the PCO2 to be elevated, so to make sure the pH is normalized. But in this kind of cases, actually the pH is not increased at all. It's not reducing to normal level, which is 7.45. So what should we, how is the answer for this kind of case? So we call it is a partially compensated metabolic alkalosis. Okay, because the pH doesn't reach the normal level, not like the previous case. So that's why we call it partially compensated metabolic alkalosis. Okay. Okay, now we go for the last exercise. Okay, the number 4. Okay, now pH 7.3. Okay, and then PaCO2 is 50 millimeter mercury. And last one is bicarb, is 30 millimole per liter. Okay, so now the pH is acidic, of course, 7.3, less than 7.35. How about the PCO2 is elevated? Okay, remember, pH is low, PCO2 is high, means that it's a respiratory causes. Okay, and the bicarb is elevated because why? To reduce the acidity of the blood so that the pH can be increased. However, in this kind of case, the pH doesn't reach the normal level. So how do we say this? We call it partially compensated respiratory alkalosis. So I think that's all for today. This is all my presentation for today. So okay, so I will get back to Dr. Hafsah for the next session.
Dr. Iskandar Mirza for the excellent presentation, and I hope everybody gained good understanding on ABG. That was a very good overview of the basics. And to me, based on my experience, not only as a doctor, but in the past medical student and also as a clinical lecturer, the most important thing that distinguishes between a good medical student and a good medical doctor is actually good foundation in basics. You know, there's no point learning about the advanced subject or topic without having a good foundation in basics. And the things that you are learning today, the basics, are saving lives every day. If you want to put it into perspective, this is what we want to focus on, the skills that actually saves lives in daily practice in medical world. So thank you so much, Dr. Iskandar. That was excellent. And now I think we have a few questions.
Yeah. Can I pick up some questions then, Hafsa?
I think before we forget, there was somebody asking about CPD points. We are working towards that. That is in our plan, and we'll keep you updated. So stay tuned to all our social media platforms, especially Twitter, but we will update on all our social media platforms about CPD, about our next session, which is next week, just to give you a bit of a clue. And yeah, for the next session is Q&A, and I'll pass on the floor to Dr. Rafida.
Okay, thank you, Hafsa. Hi again, everyone. My name is Rafida. I'm an nephrologist from working in Putrajaya. I think let's go to the few of the questions. I can see all of you have got actually quite good basic understanding in ABG. Maybe let's pick up those questions. The first one, for the first exercise, I think the first question goes, why was the bicarb? Why the bicarb does not increase since it is alkalosis? That was the question. Maybe it's your first case code. Is?
Okay. Okay. Why the bicarb is not increased? Okay. Let me go to the first exercise. Okay. Wait. Is it this one, the question?
Okay, the question is for the first exercise, why is the bicarb not
Hello?
increased? Dengar. Is the
Betul,
first exercise, dengar tak?
dengar. Okay. Why
Okay,
for the first exercise, why the bicarb is not
that's
increased?
not increased.
Okay.
Yeah, it's 19 kan. So since
Okay.
it is alkalosis, that was the question.
Okay. Okay. So from this actually we want to know whether the patient whether there's a compensatory mechanism or not for this kind of cases. Okay. So when the pH is on the lower side and then the PCO2 is higher, means that this one is a mixed respiratory and also alkalotic actually cases. But when you see that the most prominent part is the PCO2 is very high, means that the most prominent part here that causing the pH to be a bit low is because of the respiratory. Okay, so because of this, and then also the bicarb also by right supposed to be increased. However, in this kind of cases, it's strictly because there's a mixed component. So that's why actually we call it compensated respiratory acidosis from this kind of case. Okay, because the PaCO2 is much more higher compared to the bicarb level. Okay, I'm really sorry because this question is a bit difficult. Honestly, it's quite difficult. Okay, but how do you interpret is you see the pH 7.36, which is lesser to the acidic value, but the PCO2 is a bit higher. So the more we see which one is much more higher compared to the component. If the PCO2 is much more higher, means that the predominant is from the respiratory causes. So that's why we call it compulsory respiratory acidosis in this kind of case.
Okay, thanks. What your third exercise? Can you go to the number 3?
Okay.
Somebody's asked, I think a couple of questions here asking why the answer is partially compensated but not decompensated.
Oh, actually, the term is
Oh,
partially compensated and
yeah,
decompensated is the same thing. Actually,
yeah.
it's the same definition. Okay, so
Just
actually,
I
it's the
think
same
that
thing.
it's more if you talk about decompensated, I'm thinking about more dengue, you know.
Yes,
So in
yes, yes, true,
ABG,
true.
yeah, in ABG, you'll probably call it as partially compensated rather than decompensated lah. Okay, so another question, excellent questions here. Just now I had a good one. This is probably going to be your, your subsequent, what do you call that, advanced ABG presentation. But the question is how to differentiate between the fully compensated, partially compensated, and uncompensated. I think uncompensated we
Okay.
don't really use in ABGs, in cases
Yes.
we call it either partially or fully or compensated. Yeah, I'll let you explain.
Okay. So if it's compensated, means that the pH will be within normal range, pH 7.35 to 7.45. Okay. But if the pH is below than that, even though they already have a compensatory mechanism, means that it's a partially compensated. We don't say it's uncompensated or decompensated. It's a partially. We use that word. So it depends on the pH. If the pH is not in normal range, means that it's a partially compensated. That's all. If the pH in normal range, it's a compensated.
Yeah. So the other question here is how do you differentiate between acute, chronic, and acute or chronic condition? This is going to be very difficult actually.
Okay.
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 What do you?
So actually, I've shared before this the slide. Wait, I go for the first. Actually, I show you there's a table. There's table previously what to expect when you have a expected compensation or not. Okay, Dr. Rafida, can you see my table from the slide?
I can, but
Okay, okay.
not very
So
clear, but can.
okay, so okay, now we see for the acute respiratory acidosis only, because we have the acute and chronic respiratory acidosis. So in acute respiratory acidosis, the increase will be a bit only. The way how to calculate, this is the calculation that you can use. You can look at the PaCO2, you divide it by 10, plus minus 3. So that's the how many increase in bicarb supposed to be happening in this acute respiratory acidosis. Okay. However, in chronic respiratory acidosis, the increase in the bicarb supposed to be 3.5 times from the level of the acute respiratory acidosis. So actually you can calculate it if you want it. It's a PaCO2 divided by 10. So it's quite easy. And then you just time by 3.5, then you know if there's a really high, more than 3.5, means that it's a chronic respiratory acidosis. Same goes to the metabolic acute respiratory alkalosis or chronic respiratory alkalosis. If acute, you can just calculate the bicarb level, 2 times the PaCO2 divided by 10. But in chronic respiratory alkalosis, the level is supposed to be 5 times. Then the 5 to 7 times is much more higher compared to the acute respiratory alkalosis. This one you can calculate, actually, it's quite easy. But to remember it, actually, it's quite easy. If you make it as a daily habit, it will be easier for you.
In a way, to summarize, actually, to differentiate between acute and chronic is the degree of the increase in bicarb. Isn't that right?
Yes, it's true, Dr. Hafsa.
Just to put it in short, just to look at the degree of bicarb there. Okay.
But I would say it's not common. I mean, the things that we see more commonly are metabolic acidosis and respiratory acidosis, isn't it? The others are relatively a little bit uncommon, but can happen. But the two most things that we see are those things.
Make sure you know about respiratory acidosis and metabolic acidosis first, and then you can focus on the common ones, and then cover the less common ones. So understand the two first, and then you can understand the less common ones better.
Yes,
there is a
true.
question. Yeah, there's a question. I completely echo that. You really have to know your metabolic acidosis very well and your respiratory acidosis well, and then the other two. There's a question about is it possible for the patient to have both respiratory and metabolic acidosis alkalosis? You probably have you can't have respiratory acidosis alkalosis together, but you can have one of respiratory, one of metabolic, isn't it? Whatever combination, right?
Yes,
you can have both
it's true.
Yeah.
It's true when a patient have when patient have a severe sepsis with a respiratory component, such as the kidney also having a problem. Kidney also cannot compensate the compensatory mechanism, and then the patient came with respiratory problem. So it can be both metabolic and respiratory alkalosis also can present in one time. Okay. However, it's quite advanced for you guys for this topic. I will explain more on the next session. Where we talk more about the anion gap and how to actually to make sense with the anion gap and what is the causes for each of the component. Okay.
Another question. Your last exercise, is it 4 or 5? Why is
4.
it alkalosis? Is there a 5? No.
Sorry, no 5. It's a 4. Actually, sorry, I make a mistake just now. I just correct it. It's acidosis. It's not alkalosis. I'm really sorry about it.
Okay.
Okay.
So it's acidosis lah. It's not alkalosis.
Acidosis.
Yeah. So somebody is asking. Very good, you picked it up. Yeah.
Yeah.
That means they're paying attention.
Yes, paying very good attention. Yes.
That's good.
Yeah. Okay. So anything else? Any other questions? I mean, somebody asked about base access, but I think it's a bit. It's probably for the next session.
Yes. We will do it on the next session.
I think this is a very question, Rafida, the last one.
Also, ada very good question. What's the difference between ABG and VBG in interpretation?
Okay, what difference between ABG and VBG? Okay, it's quite
easy. Talk about practical as well.
Yeah. So ABG is arterial blood gases and VBG is venous blood gases. So the only difference between that is the partial pressure of the oxygen level. That's mostly because we want to see about that. If the patient on respiratory support, either venti mask, face mask, or intubated, so we are prefer to see the ABG level, arterial blood gases level, compared to the venous blood gases, because you know how to actually whether to increase the ventilatory support or to reduce the ventilatory support, or to reduce the oxygen concentration to the patient. That's the main actually difference between the ABG and VBG. Okay, so that the ABG, but we prefer to do ABG honestly. But the difference for the patient. Now is for the one that I told you before. This is the perspective from the doctor. But for the patient, ABG much more painful compared to VBG because it's very deep. You have to poke very deep to get the arterial line, and some of them have to poke many times because it's very difficult, no, to do a VBG, ABG. But however, for the VBG, you just can poke any vein that is popped from your tourniquet. So yeah, I think that's it. The ABG mostly we want to know the oxygenation for the patient. It tells you the correct way whether want to increase or reduce the oxygenation.
Yeah, and for my renal patient, nephro patient, I don't mind just having a venous blood gas because I'm more interested in the pH and the bicarb. So I will obviously, as you know, taking what do you call that, arterial blood gas is not as simple as venous blood gas, huh?
Yes, it's true.
Yeah. So another interesting question. It's all very practical question. I think it's very important. They're asking why you have to put venous or blood gas in ice pack.
So pardon me? Or ice pack?
Ah.
Oh, okay, okay. This
Very practical.
because actually if I'm not mistaken, why you really need to put in ice pack is because you actually, if you didn't put it, actually the blood actually can actually oxidize or become more what we call this, the blood won't be will be showing the normal way because it's slower the metabolism inside the blood. So if you put the blood in the ice pack compared to in the room air, so if you didn't put in the ice pack, it won't show the real result of the patient ABG or VBG status. That's why you really need to put the ice pack so that it slows the metabolism inside the blood, so that you can get the correct value from the patient.
Okay. There's a question about in what condition we need to do ABG. I think with ABG stat, I think you answered that question just now. Like in oxygenation and so on. That patients in ICU or needing BiPAP or needing to know oxygen level, you need to do ABG. The other question is okay. Of course, VBG. Somebody's asking VBG. Who? When do you prefer VBG versus ABG? I think we've answered that question. Yes. The other person that we had a question is, how do we know that ABG is not mixed with venous blood? How
the ABG? Okay, it's quite easy because you can see, look, actually at the component of ABG, you can see the SaO2 level. Is the oxygen level of the blood itself. If you see that the SaO2 is very low, however, when you check the oximeter from the patient, is a very good oxygenation. You can see that it's more than 90%. However, your BBG shows the PO2 is less than that, which that actually is not a real arterial blood gases. Probably you already poke the venous, because sometimes our vein and artery overlap each other. Okay, so that's the most easiest way. When you see the PaO2, the oxygen saturation from the ABG is very low compared to the one that you actually check from the saturation oxygen from the bedside. It's not correlating with that. Actually, it's a VBG. That is how I usually use how to interpret whether it's arterial or venous blood gases. Usually the venous one, the PO2 and also the oxygen saturation will be very low compared to the arterial one.
Yeah, thanks. Just a matter of tips as well. Sometimes when my renal patients, we insert catheter in the femoral side, we're not sure whether it's artery or venous. That's how we whether it's in the femoral artery or it's a femoral vein. That's why sometimes the doctors will ask you to check blood gas from the catheter, so that we know where the catheter is situated in, so we can differentiate whether from the venous blood gas whether the catheter is in the vein or the artery, that way. Yes. Okay. So another question is, can we also conduct ABG via catheter? I think can, isn't it? If the catheter is in an arterial like
Yeah, arterial
in
line.
ICU kan?
Yes. So
In ICU you have an arterial line, for example, so you can do an ABG from that way. Okay. So how? Okay, yeah, it's very good questions. You know, this is also very practical. How do you prepare the ABG in terms of heparin? I think a lot of
heparin.
a lot of young doctors, when they reach the lab, it's plotted, kan? So
Yes.
yeah, the practical thing of really preparing your ABG is very important as well. Maybe you can answer it.
Okay, so actually it's very easy. You need with a 1 cc syringe. It's a very small one, the smallest syringe, and then you just put infuse the heparinol inside the syringe, and then you have to take it out all. After you infuse all inside the syringe, and you take it out all until at the end. Okay, then you poke the patient using that. Or maybe after this, I should actually prepare a video for you guys so that easier for you to understand how to take a ABG. By talking here, I think not most of you won't be understand how actually the proper way lah. But you don't need a lot of heparin inside the syringe. You just have to just infuse and then take it out everything. So then means that all the surrounding of the inside the syringe already have heparinol already.
Okay. So another question is, which one is more accurate between arterial and venous blood gas in terms of electrolytes, lactate and glucose?
Okay, for the lactate, I think it doesn't. I think it won't have any much effect. You know, as I told you, most the level should be almost the same. The only difference should be the partial pressure of the oxygen. That one is the most difference between the ABG and VBG. However, the lactate or the glucose level, if you take ABG also, you can follow that. VBG also, you can follow that. No one actually gonna question you if you follow from the ABG. As long as your machine is well calibrated, so it's supposed to be the same result. The only difference is the oxidation inside the blood. That's what we want to see lah.
So another practical question, which I quite like as well. How do you differentiate between artery and vein before blood taking besides palpating for pulsatility from Nur Atika? I mean what I do, you can expand on that. But the way I take, the way I definitely use the pulsatility, but in terms of doing ABG, you can know if it's an artery, there will be a apa? Suddenly it will come out, right? There will be a pressure out, rather than if it's a vein, it won't be coming out automatically. You have to pull. So, is there anything else you want to add?
Actually, the color for ABG is very red. It's a merah muda. How do we say in English? Merah muda. It's like my shirt now.
Your shirt,
I think like like my shirt. And then you can see if vein is like the Khairul Hafiz shirt. It's like that maroon, bit maroon color. Okay, that's how the venous blood gases will show lah. It's very red because it's very nice, and also when you poke, and like Dr. Rafida said, it will actually backflow to your syringe. You can see it move the syringe moves by itself because of the pressure from the artery lah. Okay, that's how it is. But for those who housemen or junior doctors, you have to practice more and more and more. It's very difficult actually, but once you practice, actually you can become better, maybe better than I also, because now specialists don't do ABG. It's true. So most
that's terrible.
Yes, we have a medical officer. So actually, the more you practice, the better you become lah. For this one.
I'm kidding. So I'm just kidding there. I mean, I still do sometimes, but yeah, I agree with you. The ones with more experience, the medical officers, are really quite good at it. As you go on getting older, you probably the one, the patient probably don't want you there while somebody wants to take your ABG. Okay, this is excellent. Many questions. So for example, one question here: if you have a normal pH, 7.4, I think you've explained this actually. Probably just a quick recap of it. if it's a compensated normal pH like 7.4, how would you know whether it's acidosis or alkalosis? Again, as you mentioned just now, you look at the PCO2 and bicarb kan?
Okay.
Yeah.
So, okay, if the pH is normal, okay, now you see which one is the most prominent from the BaCO2 or the bicarb level. If the level of bicarb is very low, and then the PCO2 is very high, then you have to say, but this 7.4 is actually more than the normal one, almost half of the normal part. So you can see usually as I told you before, the compulsory mechanism will not really make the pH go to normal part. However, they will go to the upper limit or lower limit of the normal side. Okay, if the 7.4 is very nice, actually the ABG is a real good ABG, but in real life you will see that it's supposed to be like 7.36 or 7.46. So it will make you a bit have an idea that the patient actually having a bit acidic of the component. Then from there you can know it's either the PCO2 is high, then it shows that it's a respiratory causes, or the bicarb is low, it's a metabolic causes. Same goes to when the pH is 7.45, then you see there's the BaCO2 at the bicarb level. If the PCO2 is a respiratory causes, or if the bicarb is very high, is a metabolic causes. So it's really you see overall how to interpret this ABG. Yeah?
Okay, maybe we get one last question, yeah, Hafsa. I think it's so many questions, which is excellent. You guys have been obviously listening and understanding fairly well. You know, there's one question here versus a blood gas, using the blood gas machine and the lab machine. Kan, like for example, if you like in ICU, for example, you sometimes use like the machine in the ICU, kan. So her question, I remember the question was, which one's more accurate? Would you like send it to the lab ones or the ones with the machine in ICU?
Actually, it shouldn't be any problem. Both are actually is going to be accurate. But when we want to send to the lab one is when you want to calculate the anion gap. No, sometimes you want to know the serum osmol. Actually, sorry, not anion gap, it's a serum osmolarity. Yeah, because why? The one that you send to the lab, the serum osmol they will calculate the other component of the negative ion or positive ion, compared to the one that we calculate using the ABG itself. So that's why the only difference is the serum osmol. However, the result for the VBG and ABG will be the same. If you want to know whether it's a respiratory or metabolic causes, is enough already. But if you want to know the serum osmol, the good one, you still have to send to the lab, because you have to compare the one that you calculate from the ABG and from the one that you from the lab, because the lab have extra calculation with the other ion that is not included in the normal serum osmol calculation. I think that's the only difference.
Yeah, and then to add to that, the machines in the ICUs, for example, they are basically POCT, a point of care testing, so they need to be maintained and all that. I mean, it's good to obviously send labs, but if you're managing a patient in ICU, you need blood gas every other hour, so it's not feasible as well. So that's that's why you use the machines in ICUs, which is fine. I think as long as you see a trend, I think that's fine. So I'm going to stop my question. There are so many questions. Again, thank you so much, everyone. I'm going to stop there, and maybe I'll let Hafsa take over. Thank you so much, everyone.
Thank you, Dr. and Dr. Is, for answering the questions there. I think there are a few take-home messages today. Okay, number one is that arterial blood gas is a really important skill in terms of interpretation of it in daily practice, especially in the acute patients, as patients with acute respiratory distress. It's the most common one that we see. And it's very important to know the respiratory acidosis and metabolic acidosis well, because these are the top two presentations in daily practice. So I think Dr. Iskandar has given a hint on his next session. So we will update you on when that's going to happen. I have to say, I'm glad to see that we are in full capacity for this session, and we hope to expand next time. So give us your feedback. Thank you for your questions, but thank you for your participations. I can see that there are medical students, there are doctors, MAs, and we will welcome everyone from the medical fraternity, because we would like to know what you need in order to give effective teaching. So there's no point for us to deliver something that you don't need, or that is not relevant to your practice. So please give us feedback on Twitter, Facebook, Instagram. If you can maybe focus on Twitter, we'll update you on the next session. Our next session will be next week on Sunday at 8:30 to 9:30 p.m. Malaysian time, and it will be burnout among junior doctors. That's the topic. And the guest speaker will be Dr. Rostam, who's a psychiatrist, a member of MedTweetMY, and we also have junior doctors as well as our guests to get their perspective on burnout among junior doctors. So we have Dr. Muhammad Ashraf Saharuddin and Dr. Abdul Hazwan bin Jamaluddin. So we do hope that you can join us next week, because burnout is really common in among healthcare workers, not only doctors. And instead of talking rhetorics, we would like to know how can we actually solve the problem? How can we empower healthcare workers to deal with the stress at work? And together we can, solve this at our own workplace and help our own juniors to cope with this problem and overcome it, and get out of that situation so that they can continue on with this career. It is a challenging career. We don't expect it to be a bed of roses, but we do want to empower the junior doctors so that they can carry on and their tasks as effectively as a doctor. So I think that's all for now. Unfortunately, we have come to an end. Again, we hope to see you next week, and we have a few interesting topics lined up. And thank you so much. I think in the chat room, I can see my ex-students are also there. I welcome students also from outside Malaysia, Ireland, UK, Middle East, and everywhere. You are also welcome. We are open to everyone in the medical fraternity. And if there's anyone who's non-Malaysian who are interested, we will also welcome you. I think that's all for now. Thank you so much for the overwhelming response and the positive feedback. We see you next time, inshallah. Assalamualaikum.